Welcome to Global Liver Institute's webinar, Innovations in Hepatic Encephalopathy and Acute-on-Chronic Liver Failure, Key Insights Towards Better Care. At GLI, we're dedicated to raising awareness, education, and engagement around emerging liver health research that can make lasting impact in the lives of patients and their caregivers. Hi, I'm Larry Holden, President and CEO at GLI. Today, we're going to be exploring new data and recommendations for both hepatic encephalopathy and acute-on-chronic liver failure. These serious conditions are greatly impacting patients daily, but with increased visibility and awareness and proactive care, we can work together towards better outcomes for patients with HE and ACLF. During the course of these presentations, we invite you to submit your questions using the Q&A feature. Our speakers will do their best to answer your questions. Now let's introduce our experts. Dr. Richard Manch is a board-certified physician and chief of hepatology with Viral Elimination Centers and Arizona Liver Health. He graduated from SUNY Buffalo and holds a master's in health administration from the University of Colorado. Dr. Manch is a fellow of the American Association for the Study of Liver Disease and several other prominent medical societies. He was instrumental in establishing 2 liver transplant programs in Arizona and developed an extensive network of liver disease outreach clinics statewide. Today, his work in telementoring has improved access to specialized hepatology care for medically underserved areas, holding liver clinics across the state to enhance rural healthcare access. Dr. Jennifer Lai is a hepatologist and endowed professor of liver health and transplantation at UCSF, where she directs their clinical research. She serves as principal investigator of the patient-facing research core. Her research, funded by the National Institutes of Health since 2013, explores the patient experience in advanced chronic liver disease. Dr. Lai also mentors the next generation of researchers, receiving a K24 Mentoring Award in Patient-Oriented Research and UCSF's Distinguished Award in Mentoring in 2023. She currently serves as an associate editor for Hepatology magazine. Melanie Smith is a passionate liver patient advocate living with MASH-related cirrhosis and HE. Since 2011, she has facilitated online support groups for those impacted by fatty liver disease, NASH-MASH, cirrhosis, liver transplantation, and HE, helping connect those patients, families, and caregivers. Her background in supporting individuals with developmental disabilities complements her volunteer work in hospice care. Melanie cherishes spending time with her husband, Toby, their adult sons, and extended family, and enjoys thrifting and exploring antique stores in her free time. Thank you all for joining us. Let's get started.
Welcome, everyone. I'm Richard Manch. I appreciate the opportunity to talk to everyone about hepatic encephalopathy. This is a very common and quite important complication of liver disease. And it's certainly an area where there's continued controversy and confusion. So it's good that we have an opportunity to talk about it. Next slide, please. So as far as some definitions, just to kind of set the stage, hepatic encephalopathy is a potentially reversible, and that's very important. This is a reversible condition which affects the nervous system and also causes what we would refer to as psychiatric abnormalities in patients. Usually patients that have liver disease that's significant enough to affect the function of the liver. It's also related to something called portosystemic shunting, which simply means there's not enough blood getting back to the liver through the main vein going into the liver from the intestines. It can be obvious or it can be very subtle. And when it's very subtle, it's hard to detect it without testing. So that's called minimal hepatic encephalopathy. And you have to work a little bit with the patient to kind of bring that out. The other thing I want to clarify, since this term comes up in my discussion, and probably Dr. Lai's as well, is differentiating what we call compensated versus decompensated cirrhosis, or compensated versus decompensated liver disease. If you're compensated, it means that although you have liver damage, your liver function is still relatively preserved. And for all intents and purposes, you seem normal. If you're decompensated, you've begun to have a complication. And once patients are decompensated from their liver disease, things get a little bit more serious. And we pay much more attention to those circumstances and see those patients more frequently and discuss with patients very specifically what they need to do, what they shouldn't do, and what their options are. Next slide. So I don't want to get too scientific this early in the morning, but it's all about ammonia, which the scientific symbol for that is NH3, and the buildup of ammonia in places where it shouldn't belong, especially in the brain. So the body has a certain level of ammonia, which is relatively low in the bloodstream, and very small amounts reach the brain. And that's important because ammonia has a toxic effect on the brain and affects how well your brain functions. It also goes into other parts of the body, such as the muscle, the kidney, and so on. And what it represents is a breakdown of protein that's ingested by people and processed in the liver. And if the liver isn't functioning well, ammonia hangs around at higher levels in the blood and then begins to do the effects that we refer to as HE or hepatic encephalopathy. So we may have questions about that, but let's move on. Next slide. So it is quite common in a practice like ours, where I see nothing but liver patients all day, and we are in a setting where I no longer work in transplant, but we have several community-based liver clinics, and we get lots of referrals of patients that have been really suffering with liver disease for a long time and may not have easy access to a liver program or a transplant program. So we see this complication every single day in clinics that we have. So up to 45% of patients with decompensated cirrhosis, in other words, cirrhosis bad enough that their liver function is beginning to fail, and the majority of patients walking around with cirrhosis are not yet decompensated, and decompensation can often be avoided, but that's kind of a separate discussion. But for them to have at least some signs of hepatic encephalopathy is really quite common, especially if you think about it and look for it as a provider. There's a 20% annual risk of development of hepatic encephalopathy in patients with liver disease that is still pretty good. If their liver function is still good, they're still compensated, they haven't had a complication yet. There's about a 1 in 5 shot per year that they'll develop this. And once they have encephalopathy, that counts as one of the criteria for decompensation. It's a sign that, as I mentioned in the last bullet point there, it's a sign or a signal that that patient is starting to turn the corner and getting worse. And the challenge with chronic liver disease is there may be no symptoms at all until you reach that point where you begin to decompensate, and then things happen very quickly and shockingly rapidly from a patient's perspective. I often hear patients say, "I can't believe how quickly I got sick." And I remind them, well, this has probably been developing in your liver for maybe decades, and you're just at the point now where you just don't have enough healthy liver cells to keep the liver functioning at normal levels, and so things are starting to decline. So if you look hard for this, and sometimes it's very subtle, and we'll talk a little bit about that, most patients that are still compensated, you can probably find the earliest signs that they might be beginning to have encephalopathy, but sometimes it's a little bit of work to find that. And often our clinics, we don't do a lot of testing in patients that don't obviously have signs of it because it takes quite a bit of time, and we're usually rushed a bit in clinic. But as I said, if we diagnose a patient with encephalopathy, it means things are getting worse. It's important. Next slide. So these statistics I find are not recent. They're probably not a lot worse now, but encephalopathy accounts for an incredibly large number of hospitalizations in liver patients. And the same patient can be in and out of the hospital 6, 7, even 10 times a year, in and out, in and out. They get better, they get worse. The condition tends to kind of oscillate. It gets better, it gets worse for a number of reasons. And they can be in the hospital a week or so, and this consumes a huge amount of resources. So the cost of this complication, because of multiple events requiring emergency department visits, hospitalizations, is really overwhelming. Next slide. So there are types or stages. Well, types really, because stages is more assessing the severity of the encephalopathy. But the type A is what we would occasionally see in someone that acutely has liver failure. And I think Dr. Lai is going to talk a little bit about that subject after I do. But for example, if a patient either purposely or inadvertently takes too much Tylenol and goes into liver failure without pre-existing liver disease, encephalopathy or this mental dysfunction, neurological dysfunction can be one of the first things that might show up when the patient's getting sick. The type B is related specifically to portal hypertension, generally related to placement of a shunt, a transjugular intrahepatic portosystemic shunt, which is often abbreviated as TIPS. And this is not quite accurate the way this slide is presented. I should have corrected it. It doesn't necessarily imply that there's no intrinsic liver disease. These are often done in patients with liver disease to control the complication of ascites or varices. The third type is common, and what's really what we're focused on is encephalopathy associated with cirrhosis and the complication of too much pressure in the portal vein, allowing not enough blood to flow through the liver. The blood bypasses the liver, and the liver doesn't have an opportunity to detoxify the blood adequately, so too much ammonia builds up in the system and in the brain and causes these changes. Next slide. So this is the grades I was mentioning, and I think in clinical practice, I don't really use this or talk about this or record this in my documentation. We're a little bit more subjective, but the early stages, stage 1 and 2, it can be subtle, but are not as severe. The patient may have a disruption in their sleep pattern. They may have a condition called asterixis, which is a unique type of tremor, a kind of an up and down flapping of the hands, like I'm doing here, if you're seeing me, which is characteristic of this particular condition. Sometimes I have to hold the patient's hand backward and then kind of feel it sort of pulsate. This is not the same as just an essential tremor or a Parkinson's disease tremor, which it looks very different. And this is, again, something you have to kind of look for. But in the more severe cases, which would be grade 2, the asterixis can be obvious. The patient could be sitting there talking to you, and they're having this kind of flapping tremor, this up and down tremor, which you can also see in the lower extremities in the feet. But there can be other changes like the lack of focus, personality changes, disorientation. The person has trouble finding their way around the house, or difficulty driving and trying, even with GPS, trying to get where they're going. And by the way, people with this diagnosis are not supposed to be driving, and it's hard to enforce. But if you have any level of encephalopathy, you really should stay away from being in the driver's seat. Difficult thing to impose in communities like mine. I'm in Phoenix, where you can't get around without a car. But lethargy, just a change that can come on gradually and can be very intermittent and hard to detect. The more severe grades, grade 3 and grade 4, this is usually a situation where a patient's going to be hospitalized. They're so sleepy they can barely be aroused, or they can be comatose. In other words, can't be aroused. And even though the coma can be very profound and very frightening, it can be readily reversed in most cases once the patient is hospitalized and gets on treatment. But again, there's other changes. There's a huge variety of changes that can occur. It can be kind of bizarre behavior or disorientation. In fact, in older patients, it might be misdiagnosed as the onset of dementia or Alzheimer's. These patients often need a good, careful evaluation to distinguish that. Next slide. So this sort of depicts this kind of intermittent situation, which is mostly what I see. Now, the green line at the bottom represents this minimal type that you cannot detect without testing. But the yellow line, I think, is, in my experience, the most common. Comes and goes, often due to the fact that in the morning, the patient's with their spouse, they're taking their lactulose, they're doing everything they're supposed to do. Then the spouse goes off to work all day. The patient stops taking their lactulose, and then spouse comes home in the evening, and the patient is again not in good shape. And then some patients, particularly the ones with more severe liver disease, they're continuously in this situation. But to have it kind of come and go, patient's great at one point and bad at another point is not unusual at all. And again, that's why it's sometimes misdiagnosed as Alzheimer's, which can seem similar. Next slide. So diagnosis is clinical, which means that really the provider has to touch and see the patient. This is difficult to do online or with a televisit, and it should not be based. And we fight this battle constantly. And just checking this morning on what was on the internet, there's still misinformation about the ammonia blood test. Hepatologists generally don't order this test, but it's widely ordered by primary care providers and emergency department providers, and people depend on it. It has limited usefulness in the way that it's usually done, which is just drawing some blood from the patient, what we call venous blood or blood from a vein, without any special preparation of the specimen. It's not an accurate test, but it's widely used and widely misunderstood. So although we have patients constantly talking to us about their ammonia levels and providers that are ordering them frequently, we try to discourage depending on the ammonia blood test for diagnosis. It's a clinical diagnosis. You have to assess the patient, ask them questions, examine them carefully. You have to rule out other things like central nervous system infections, meningitis, encephalitis, something called Wernicke's encephalopathy, which I recently saw a patient that was confused about that because his provider was referring to his condition as Wernicke's encephalopathy. And that's really a non-reversible permanent form of brain damage, also often associated with alcohol use disorders. A disease called Wilson's disease, which is not very common, which relates to buildup of copper in the body. It's often precipitated. You want to know what's brought it on in a patient that's prone to have this, but it's often precipitated by the patient not being compliant with their lactulose, or if they've been given something like a sedative, a sleeping pill, tranquilizer, strong painkillers in response to the request that they're not feeling well, they have pain, they have trouble sleeping. If you have a patient with marginal liver function and they don't sleep well, probably the worst thing to do is giving them some kind of sleeping aid other than maybe a little bit of Benadryl. Next slide. The ammonia levels are elevated in patients with encephalopathy, but you can't depend on them for diagnosis because they're often elevated in other patients, whether they have cirrhosis or not. I frequently see these tests done in the emergency department with patients that have no liver disease whatsoever, but maybe had a few drinks before they came in. And so someone did this test, diagnosed them with encephalopathy, and sent them immediately into the hospital or referred them to a specialist without really any evidence of liver disease at all. So it's misused, and I can't emphasize this enough, and I know we'll get questions about it. It doesn't correlate well. Like the higher the ammonia level doesn't necessarily mean the patient is worse. EEGs are not routinely done for diagnosis, in other words, brainwave tests. You do sometimes have to do imaging of the brain, like an MRI or a CT. Although it's not helpful with diagnosis of encephalopathy, it's important for ruling out other things because remember, these patients often fall. They can have head injuries. They can have bleeding in the brain. They can have pre-existing abnormalities. So it's usually is appropriate in the ED to do imaging of the brain, a CT of the brain, but not pneumonia level, even though we can't stop them from doing those. And I understand that. Next slide. This is an example of one of those tests that anybody can do anywhere. I don't do it quite this way, but it's called a number connection test. If you wanted to bring out this diagnosis in someone that has the most subtle suspicion of encephalopathy, and what I do is I just write a bunch of numbers on a page randomly, and I just see if the patient can do it or not. They take a pencil, they start with 1, and they draw a line connecting each number in order. Seems simple, but and I don't put these many numbers on the page, and I don't time it. And quite honestly, I can't do this in less than 30 seconds because I'm too compulsive. So I don't time it, but I just see if they can do it. There's other things you can do. Try to get them to write their name. See if their handwriting is even remotely discernible. Try to have them draw something like a 5-pointed star and then have them copy it. And, these simple things that people can do in a number connection test, the way they show it here, it doesn't look so simple. And there's some other clever things that you can do on smartphones. But the trouble in clinical practice is we often don't have time to do this. But if you have time, I think it's helpful. Another way to diagnose it, but again, emphasizing that this is a clinical, not a blood test diagnosis. So next slide. So we talked about the minimal encephalopathy. You have to do tests for it, but it can be so subtle that it kind of screw up somebody's lifestyle without realizing what's going on. It could be an explanation for a tendency to have traffic accidents or accidents at work with no other obvious signs. It's difficult to do these tests in clinic. And some experts feel, and this is a little bit controversial, that if the patient's got reversal of their sleep pattern and they're up all night and sleep all day, that this could be an early sign of encephalopathy. And I would say it may be, it may not be. It's not 100% reliable because other people have this issue too. Next slide. So as far as the treatment, if it's severe, they need to go to the hospital. If the patient's barely arousable or comatose, immediately 911, get them to the hospital. Otherwise, in the usual clinical setting, it doesn't require immediate hospitalization, but these patients need to be carefully evaluated for precipitating factors, something that might have caused it, an infection, a UTI, gastrointestinal bleeding. I'll talk a little bit more about that. Next slide. So here's the things that can set it off. I put in red the ones that I think we see the most. Somebody got a benzo for sedation or anxiety, narcotics for pain. Obviously, alcohol. Patient goes on a binge with pre-existing liver disease, and they were felt to be intoxicated, but they're actually encephalopathic. Constipation for patients that are supposed to be taking their lactulose. One of the ways you assess it is the bowel movements should be occurring 2 or 3 times a day. Non-compliance, and then some other things like, as I mentioned, bleeding, gastrointestinal bleeding, infection somewhere, infection of the fluid in the abdomen if they have ascites. Sometimes if the patient's going in and getting all the ascites removed at one time, that can cause it, and it can cause other issues such as impairing the kidney function. It's rare to have this precipitated by eating too much protein because people tend to not eat much protein. We're often trying to get them to eat more. Or if they develop a thrombosis of the portal vein, particularly due to any cause such as pancreatic disease or trauma. Next slide. So as far as the diet, they should eat protein. The idea of restricting the protein is old-fashioned thinking. We don't recommend it anymore. They should probably try to get 60 grams of protein a day. They don't have to go crazy with protein. Vegetable protein might be better. There's this use of something called branch chain amino acids, which kind of comes and goes in our field. And some people advocate things like probiotics. The solid clinical evidence for that is kind of plus or minus. The main thing is chronic liver patients need protein. You don't restrict their protein. Next slide. So the treatment is lactulose and rifaximin. In routine clinical practice, these are often started together. Lactulose is generic and easily available. Rifaximin, there's some issues in getting it for some patients. If they have a TIPS, and I'll go into that a little bit more, and we're almost done. If they have a TIPS shunt and it's working too well, there's some cases where we'll ask the radiologist to go in and slow the flow of it a little bit so that they're not so encephalopathic. It's, if the patient gets encephalopathic after a TIPS, it means the TIPS is working. The blood is bypassing the liver, but there's not enough blood still going to the liver. So you may have to slow it down a little bit. And of course, in some cases, the patient will have a transplant and that'll cure the encephalopathy, of course. Next slide. I don't want to get scientific at this point, but just to say that the way lactulose seems to work is it's metabolized by the colon bacteria because you can't absorb it. It's a sugar that the body can't absorb, and so it makes its way through the colon. It ferments. It ends up flushing. To keep it simple, it ends up flushing the toxin out of the body in the form of NH4, which can be excreted in the stool. The body doesn't absorb lactulose. It's almost like taking lactose if you're lactose intolerant, and you get this bowel disturbance. So lactulose everyone is intolerant to lactulose, and none of us can absorb it. So it has that action within the bowel, doesn't get into your system. Next slide. And let me just mention, the way that you dose this is variable. There's no set dose, and this is a mistake I see all the time. You maybe start with 2 or 3 tablespoons a day in divided doses, and you go up or down to regulate the bowels with about 2 or 3 soft, easy to pass bowel movements a day, or whatever it takes to control the encephalopathy. If the patient's getting diarrhea, you have to slow it down. If they're still constipated, you have to increase it or add something like Miralax to get the bowels flushing better. So it usually takes 2 or 3 doses a day. If the patient's in a hospital, they can give it through a tube in the stomach or even rectally, but not as an outpatient. But as I mentioned, it's often improperly dosed, even by, I know a very well-trained specialist who regulates the lactulose dose based on the ammonia level. So that's completely wrong, and he's very well-trained, and he keeps doing that. Happens. Next slide. Rifaximin, which is really a game changer, but there's a challenge with it. It's an antibiotic that is not absorbed, almost entirely not absorbed, works only in the intestines, and changes the normal, what we call intestinal flora. We all have a lot of bacteria in our lower intestine, and it adjusts that in such a way that it resolves very effectively the symptoms of encephalopathy. And it's used together with lactulose. I think its major benefit is to reduce the amount of lactulose that a patient takes, because they generally don't like it, lactulose. And the rifaximin is only 1 pill twice a day, easy to take. However, it is expensive, and it's often hard to get it approved for patients. One of the reasons is that its actual FDA-approved indication is for prevention of recurrence, not for initial treatment. So that is a hook that the insurance companies can effectively use to deny payment of it. So there's challenges on both sides. The insurance companies don't want to pay for it, and the cost of the drug as set by the company that makes it is high. So we work with that issue constantly. It's got somewhat better. There's an older antibiotic called neomycin, which we don't recommend, but I think it's still available and it's considered an alternative, but it's not recommended. It's similar to rifaximin in that it's a so-called non-absorbed antibiotic, but some of it does get absorbed, and it can impair the patient's hearing or kidney function. And I've seen patients become totally deaf taking it chronically. It's also dangerous to the kidneys, as I mentioned. So it's really not recommended. We shouldn't be seeing people taking neomycin, which means if the insurance is denying the rifaximin, we have to hit them over the head with that. So to summarize, encephalopathy, hepatic encephalopathy is common, is seen in patients with cirrhosis who are advancing in their disease, but it's often mis or overdiagnosed. It's because the ammonia is not adequately detoxified by the liver and builds up in the brain. It's a clinical diagnosis, not based on the blood test. We don't restrict protein. They do need protein, these patients. Once it occurs, the patient needs a thorough evaluation to make sure that the precipitating factors are understood and there's no alternative diagnoses. And remember that these patients generally should be on lactose and rifaximin, although you'll have to stand on your head to get rifaximin. I think that's it, and I will turn it over to Dr. Lai. Thank you very much. Questions soon.
Thank you. Thank you so much. Dr. Manch, that was an amazing tour de force of encephalopathy for patients. I thought it was amazing. Let me just share my slides. I think that should do it. Good morning, everybody. I'm Jennifer Lai, and I have been asked to speak on the topic of acute on chronic liver failure. And I'm going to be giving this talk from the clinician's perspective, but I'm really looking forward to your questions from the patient and caregiver side. Here are my disclosures. So acute on chronic liver failure, or ACLF, potentially reversible condition in patients with chronic liver disease with or without cirrhosis that is associated with potential for multiple organ failure and high mortality within 3 months in the absence of treatment. So this is a condition in which patients are really in the acute critically ill state. It's not typically a state in which you're living at home, sort of existing in this state of acute on chronic liver failure. It's really very acute. And typically patients, almost always need to go into the hospital for when they present with this condition. One of the key defining features of this condition is that it has a high mortality in the absence of treatment. And the primary treatment, and we'll discuss more about this later, is transplant. And you can see here, this is a survival curve where this is 100% survival and this is 0% survival. And just in one very small study, you can see that in the absence of treatment, most individuals will die when they're in the most severe stages of acute on chronic liver failure. And unfortunately, at this time, there is no direct therapeutic for ACLF, but this is exactly why we are all here. As clinicians, we're here to advocate for the development of therapeutics for this very serious, very scary condition. And we depend upon you as patients, and we depend upon organizations like the Global Liver Institute to help us provide a unified voice to pharma, to the government, to the FDA, to really push for accelerated development and approval of therapeutics for ACLF. Let's talk a little bit about the clinical course and features of the typical patient with ACLF. And before we go into ACLF in particular, I wanted to talk to you about the trajectories of liver function in 3 common liver states. Now, Dr. Manch had discussed in a case of a patient with Tylenol overdose, for example, that would be acute liver failure, a patient without known underlying liver disease, typically who has a ingestion of Tylenol. And so they go from a complete liver function, and then all of a sudden they have the acute insult like the toxin of Tylenol, and then their liver function precipitates within the matter of days or weeks. So that's acute liver failure, and that's not what we're talking about with acute on chronic liver failure. Now, there's another state which is just progressive cirrhosis. So patients with underlying cirrhosis and end-stage liver disease can experience oftentimes just a slow progression. A lot of my patients just tell me, when they come into the office every 3 months, they're just a little bit worse. They have one more complication. Their ascites is a little worse. Their encephalopathy is a little worse. We now need to add rifaximin on top of lactulose, as Dr. Manch described. But that is sort of the progressive cirrhosis state. But in acute on chronic liver failure, most typically the patient has underlying advanced liver disease or underlying cirrhosis. They're sort of traveling along this progressive cirrhosis state, but then they have an acute insult. And that typical insult might be an episode of infection of their ascites, something we call spontaneous bacterial peritonitis, or an episode of acute hepatic encephalopathy, or they might get an infection, they might get COVID or something like that. And then that actually leads to an accelerated decline in their liver function that leads to this sort of precipitous drop. So they actually go from being this on the trajectory of a progressive cirrhosis track to almost like acute liver failure track, hence the name, acute on chronic liver failure. The clinical characteristics of patients with acute on chronic liver failure traditionally in the United States is very much like the characteristics of patients with underlying cirrhosis. Median age of 57, this age is going up. Every couple of years, the median age kind of creeps up by a year. Predominantly men, and this just mirrors the natural demographics of cirrhosis. And alcohol is a dominant etiology of underlying liver disease, particularly acute on chronic liver failure. In a prior cohorts, NASH was down here, or now what we call MASH, or metabolic dysfunction associated steatotic liver disease. But I will bet in the next couple of years, this MASH category is going to shoot up to the number one etiology because it is becoming the most common indication for cirrhosis. The reason for the acute on chronic liver failure, bacterial infection is number one. Other categories, usually we just can't decide which one of these combination of factors led to the acute insult and the decompensation, GI bleed, hepatic encephalopathy, renal dysfunction, and then acute alcohol. I will say that in European cohorts, we see alcohol being a dominant driver of acute on chronic liver failure. And this alcohol related is actually also rising as well in the United States. Now, it's very important as we're thinking about who is most likely to develop acute on chronic liver failure when they're in the state of just cirrhosis and the progressive decline of cirrhosis. And one of the primary risk factors for acute on chronic liver failure is the presence of prior hepatic decompensation. So the majority of people who present to the hospital and we're seeing with acute on chronic liver failure have previously had a decompensating event. So almost 3/4 of individuals have had cirrhosis decompensation. They don't go from being completely asymptomatic to all of a sudden being in the ICU with acute on chronic liver failure. Most typically, they have had ascites, they've had encephalopathy, they've had an episode of acute kidney injury in the past. So we already have a sign that their body has very little physiologic reserve to withstand stresses. And that's what this role of prior hepatic decompensation does, to give us a clue that a certain individual is more likely to develop acute on chronic liver failure. Now, I would be remiss if I didn't talk about the role of frailty, which is the primary area of my research program over the last decade. And I want to talk to you about frailty in particular because as patients and as caregivers, this is one of the primary things that we can help to mitigate. Frailty is formally defined as a distinct biologic syndrome of decreasing physiologic reserve and increasing vulnerability to health stressors. Now, just think about frailty as the layperson word. I mean, that works also in medical language. We use the word frail all the time in the same way that you would see somebody as frail. But it does actually represent this more formal construct of, underlying this frail person in front of me is this person who is much more vulnerable to stressors. It's like a car that is running on low gas. That car is much more likely to have trouble starting, much less likely to be able to accelerate. It's just much more likely to have trouble. The reason frailty is so important, or I guess if I were to portray frailty in a picture, I would portray it this way. Frailty is really one's physiologic reserve. Think about two patients, one who's not frail, one who's frail, both of whom are subjected to an acute stressor. Okay, so both of them can get acute stressors. The not frail patient will have a decline in their physiologic reserve from the acute stressor, but be able to recover from the acute stressor and recover to a point where they're not necessarily having any additional complications from that stressor. But a patient who is frail has the same drop in their physiologic reserve, but then they will have this very rocky course. They might come into the hospital with one problem, like a bacterial infection, and then they start recovering from the infection, but then we find that they get another opportunistic infection as a result of that, like they get C. difficile, or they'll get a clot because they've been in bed too much, or they get acute kidney injury. This is the person that keeps getting one complication after another because their frailty basically showed that they didn't have enough physiologic reserve to withstand that initial insult. Data have clearly shown that frailty predisposes patients to increased risk of complications with ACLF. And this is just one figure. It's a multi-center international study that shows that patients who are frail have a much higher risk of death and further decompensation as opposed to people who are less frail. So this is the cumulative risk of death or decompensation. And you can see this is just a much, much higher line at a rate of about 40% at 1 year. Now, remember the definition of acute-on-chronic liver failure was really predicated upon the idea of multi-organ failure. So the four major organs that we think about outside of the liver itself are the kidneys, the brain, circulatory dysfunction, so the heart, and the lungs. By far the most common extrahepatic or non-liver organ is going to be the kidneys, okay? But then the brain, as you just heard that excellent talk, the hepatic encephalopathy is very common in our hospitalized patients with cirrhosis and with ACLF. And then oftentimes these patients need to be supported with their blood pressure because their heart just is at its last legs and it cannot support the patient through this acute insult. When we grade severity of ACLF, we actually, in the most simplest of terms, we'll actually just add up the organs. So having none of the organs is the best state of that's not having ACLF. If you have one impairment of one organ, that's sort of ACLF 1. If you have two organs, ACLF 2, 3, and 4. There's a little bit more technicality to it, but that's the simplest way. And if, God forbid, you're ever in a situation where you have to take care of somebody with ACLF, this is probably the simplest way to just talk to a clinician about it is how are their kidneys? How is their brain? How is their heart? How are their lungs? And then when we start adding up the organs, we can just loosely categorize patients into severity of ACLF as no ACLF, ACLF 1, 2, 3. And you can see the cumulative probability of survival. So this is survival curves now. And someone without ACLF has much higher survival than someone with ACLF1, who has better survival than someone with ACLF2, who has much better survival than someone with ACLF3. So somebody with 3 organ failure or 4 organ failure is someone who is at very high risk of death. So I wanted to talk to you a little bit about the pathogenesis. So this is really, why does ACLF happen? It gets a little bit technical. So if this is turning you off, I only have 4 slides, so you can just ignore these 4 slides. But I also recognize that GLI has patients and caregivers who are extremely informed, extremely educated, and extremely empowered, and will go up in front of the FDA, will go up in front of pharma and biotech. So I really wanted to empower at least some of you who are interested with this information about this very interesting condition. Now, I want you to just understand the underlying condition of cirrhosis and portal hypertension. Now, cirrhosis leads to essentially the state in which blood cannot flow very freely through the liver. The liver should typically be like a sponge. So anytime blood goes through it, the sponge will sort of accommodate, and water or blood just flows through the sponge very easily and smoothly. And then it kind of leaks out on the other end. And then the heart just pumps it through the sponge, and that's totally fine. But now think about that sponge like a cement block. So then you push blood through it, and there's no way to accommodate it. And so in order for that same volume of blood to go through it, it just can't do it. And so it backs up into this portal vein, and the portal vein then leads to high pressure in the portal vein. And to sort of decompress that pressure, that blood will then go into different other blood vessels. And that's why we get esophageal varices. That's why we get a very big spleen, for example, that then chews up the platelets. In this state of cirrhosis and portal hypertension, one thing that happens as a result is that the heart needs to start pumping blood throughout much faster. It's sort of a long story as why that happens, but just just believe me, please take it on faith that as a result of portal hypertension, the heart needs to beat more and more blood through the system in order to make sure that blood gets to all of the organs sufficiently. And so in the state of cirrhosis, the heart is really approaching maximum capacity. There is also, because of all of this blood, here, let me go back just one, because of all of this blood that sort of went into the whole intestines, and you've got all these engorged veins, the circulation is not very good. The gut is not getting very good circulation. And so the bacteria, the gut cells, all of those are just dysfunctional. They're not getting the nutrients at the rate that it's supposed to be getting the nutrients. It's completely congested. And the gut, as you may or may not be aware, is actually one of the most important components of our immune system. It's what protects us from all of the things that we eat and all of the things that we ingest. The gut microbiome and the gut cells are so critical for protecting us against that. And now it's all congested with poor blood flow, too much blood flow, too little blood flow. And so the gut cells are super sick, and the gut bacteria become super sick. The data clearly show that there's a less diverse gut microbiome as liver disease increases. So here's a healthy person has a very diverse, very rich species count in the microbiome. Oops, sorry. And then as you get to compensated cirrhosis, there's a less diverse microbiome. And then as you get to ACLF, the microbiome is it's not very rich, and a lot of the good bacteria have died off. And so it does raise this question of, is there a role for gut microbiota manipulation to improve ACLF outcomes? This is an area of incredible research. We don't know the specific answer to it, but I would say that in my opinion, it couldn't hurt. It can't help if we really try to focus on the gut microbiome and what we can do as patients and clinicians and caregivers to really support the gut microbiome. So I'll talk about that in a little bit. And then the second thing is I talked about the sick gut cells, and what's happening is the gut cells are no longer able to sort of kiss each other and form a barrier, so they get kind of leaky and they start opening up with all of this congested blood flow, and that allows some of the bacteria that we're eating and some of the bad bacteria in our gut to leak into the circulatory system. And that actually leads to the state of chronic systemic inflammation, because the immune system is seeing a lot more bacteria that it doesn't typically see. And so it's constantly revved up to try to fight these bacteria that are leaking through at very small rates through the gut system. And the data clearly show that patients with ACLF, and as their liver disease decompensates, actually get worse and worse systemic inflammation. And so there is a question about, is there a role for targeting systemic inflammation to improve ACLF outcomes? Again, another area that is rich and ripe for research. So what happens at the bedside from a clinician's perspective? As I mentioned earlier, there is no direct therapeutic for patients with ACLF. And this is typically what it looks like for patients. If you can just imagine the patient in the bed. And as clinicians, this is really the picture that we're seeing quite literally at the foot of the bedside. And you can see that the treatment actually is that we just throw the kitchen sink at the problem. These patients are in multi-organ failure. Remember, the heart is a major system. So we're doing everything that we can to support the circulatory system. We're doing everything that we can to protect their airway when they're encephalopathic, in addition to adding the lactulose and rifaximin. We are trying to feed the individuals. We are supporting their kidneys with dialysis. We're throwing every antimicrobial on that we know of. We're feeding them with a nasogastric tube, and it really helps to have nursing staff that really is very experienced in liver care. The goal of the treatment is to buy time, because again, there's no direct treatment for ACLF. So right now, we just need to buy time for the body to heal itself, to allow the precipitant to resolve. So that this is the throwing antibiotics at it. Supporting the kidneys while they recover, supporting the variceal bleed and trying to stop the bleeding. In the most severe cases in multi-organ failure, I will say in my experience, I really am trying to buy time to get the family members together in case the patient's not going to make it. But the primary goal of ACLF, at least at my center, which is a high volume transplant center at UCSF, is to really try to prepare the patient for liver transplant, to stabilize them, and also do any sort of testing that we need to prepare them for transplant. The reason that we really want to push for transplant and get the patient to a transplant center if they are a candidate is that survival is much better with transplant than without. Here you can clearly see that this is the survival with transplant here. This is survival without transplant. There is, unfortunately, a very narrow window for liver transplantation. Remember the trajectory of the ACLF patient. 40% will recover remember what we said, buy time to allow the precipitant to resolve. And so 40% will thankfully be able to buy time, and the less frail the patient is, so the more fit they are, the much more likely that they will be on this trajectory of the recovery than on the bottom trajectory. If we transplant the patient here, it's too early, right? Because they will recover from this. Obviously, if we wait till this place where they have multi-organ failure and they have significant circulatory failure and pulmonary failure, that's going to be too late. They won't be able to survive transplant. And so there is this very, very narrow window of transplant right here, where we find, it's the Goldilocks place, not too early, not too late. And this is where therapeutics targeted towards sort of buying time within this window would be incredibly helpful to patients and clinicians. So ACLF is a scary condition, but I want to leave you with something that you can do to empower you. And with ACLF, once you develop ACLF, it's hard, it's hard as a patient to do anything about it. This is where you just got to present to a hospital, get a very experienced hepatology team to help manage. But there's so many things that you can do beforehand to try to prevent the likelihood you're going to develop higher stages of ACLF. And that is within an ounce of prevention. And I'm going to focus this on this idea of preventing and reversing frailty. Remember what we talked about, the pathogenesis of ACLF is it relates to the microbiome. So I would say feed your belly bugs, foster a healthy gut microbiome. Try to reduce anything else that can lead to systemic inflammation. And I would say that the most powerful thing that you have at your fingertips that I as a clinician can't do anything about for you is through healthier eating and exercise, and then to engage your muscles so that you're as fit as possible going into the hospital if you ever develop ACLF. So one of the key factors to feeding the belly bugs, fostering your muscles, and reducing systemic inflammation is the role of a plant-forward diet over animal products, and also a diverse diet. And one goal to try to strive for is to eat 30 plants per week. Now, the obvious plant is salad. I mean, all my patients, when I say this, they go, oh yeah, I have to eat more vegetables, but that you can't eat 30 just on vegetables alone. That's like a very time consuming job. You can't do it on just fruits and vegetables alone. Remember that plants are legumes, and there are a host of different types of legumes. So, try not to only eat black beans and pinto beans. Go to the store and buy a can of a cannellini beans, or navy beans, or red beans. Just try to vary them. Garbanzo beans. The nuts, go get a handful of mixed unsalted nuts. Seeds, pumpkin seeds, very popular for today. Go ahead and scoop those out of your pumpkin and roast them in the oven. Very delicious. Whole grains for sure. So oats, and then whole wheat. If you love pasta, go for the whole wheat pasta. If you love bread, go for the whole wheat type. And then you can diversify, and you can really sort of, game this 30 plants per week. And this is what I do with a lot of spices. So just buy, every time you go to the market for the next maybe month or two, every week, just buy one new bottle of a spice that you wouldn't normally have in your kitchen, and put it by your stove, and just throw it into your foods. There are other key things, especially for individuals with cirrhosis. You have to strive to eat more protein. And I do want to remind you that plants have tons and tons of protein. Okay. Proteins do not just need to come from animals. So the recommendation is 1.2 to 1.5 grams per kilogram. And do remember Dr. Manch's advice that even in patients with hepatic encephalopathy, we no longer restrict protein. So you still have to eat protein, even if you do have hepatic encephalopathy. And then it's very key to have a late evening snack to prevent the fasting that the body goes through during a long period of sleep overnight. So eating something before you go to bed, about 200 kilocalories, ideally with a combination of complex carbohydrates and protein together, are great. Here are some examples. I strongly prefer the use of whole foods and natural foods. Yogurt is great. Yogurt I don't have here, but nuts are great. Oh, here's yogurt. Peanut butter and whole wheat toast. Eggs. I know this is an animal product, but at least it's not land meat. And a handful of nuts. But if none of those are appealing, and this is what you reach for, then a supplement is better than nothing. Exercise is also very important, and I always talk to my patients about thinking about the frequency, intensity of exercise, how much time they spend, and the type of exercise. And this includes both aerobic activity, 3 to 5 days a week, 150 minutes total per week at a level of 5 to 6 out of 10 in intensity. And in order to help grade this intensity level, use the talk test. So you should basically be short of breath, but still be able to talk. But this is at that stage where you preferably don't want to talk that much, because you have to pause in between to get out a full sentence. And then anaerobic activity or resistance training is very important to build muscles. You actually cannot build muscles through protein alone. People think if you just eat protein, all of a sudden you become big and buff. If you don't eat protein, if you don't exercise after you eat protein, that protein and all those calories from the protein will actually just go into fat. Okay. So when you eat, do what the bodybuilders do. They eat, they drink their chocolate milk, and then they go work out 30 minutes later to basically harness and store that protein into muscle tissue. At least 2 days of resistance training a week with upper and lower body days. And don't do it too high intensity. We're talking about low intensity, and that means being able to do 10 to 15 reps and do it 2 or 3 times. So in closing, the key points around ACLF is that ACLF is a potentially reversible condition characterized by multiple organ failure and associated with a high risk of death. There is currently no direct therapeutic for ACLF, which is why it's so critical that we as clinicians are able to partner with GLI and patients and caregiver advocates in order to support therapeutic development. And you can do so much to help prepare yourself and your body for this insult of ACLF and improve your outcomes through healthier eating and exercise. Thank you very much.
Okay, thank you. Okay. There you go. Thank you both for your wonderful information. As a patient that's living with MASH-related cirrhosis and hepatic encephalopathy, I know how invaluable this information is. And I've got several questions that I would like to share and see if you would ever like to answer them. I'll kind of go from here. One of the first questions was, as a patient, I didn't know what HE was. What advice for care partners and family members would you give when they notice something is just off and different? And what's the best way to communicate with patients and family members when we've figured out we've got something going on?
I think that's a very important question, a very common scenario. And so much of effectively negotiating and navigating the healthcare system is advocating for yourself and your family. Unfortunately, our healthcare system is not optimal in many, many ways. And a lot of things don't happen unless you advocate. So I think you often have to speak to your provider about the possibility that whatever changes are occurring could be related to the patient's liver disease, and specifically in terms of encephalopathy, could this be encephalopathy? Because there's so much discussion about dementia and Alzheimer's, and it's even been an issue in the national election. So people are very aware, and there's a rush to judgment especially in a patient who's not young. And many of our liver patients have been living with liver disease for a long time, hepatitis C, metabolic dysfunction associated steatohepatitis, that they are progressing, and the fact that they have liver disease may not even be clear. So I think that's important for patients and families to raise the issue with their providers. And I think I'm saying this knowing it's a challenge, because providers are under a lot of pressure to see a lot of patients. They have demands on their time. But if you have a good provider that listens to you, one of the complaints that I hear about when patients come in and they've seen someone else is, this doctor or this provider doesn't seem to listen to me. So you have to listen. And as a patient or an advocate, you have to say, could this be liver? Could this be encephalopathy? And, there's a couple of questions in the Q&A, and one of them relates to a touchy subject about driving. And if the patient has any impairment in their sort of their cognitive function, reaction time, that sort of thing, particularly in a town like Phoenix, where I live, they should not be driving a car. And this is such a tough issue. If you've had an elderly parent who you have to get to the point where that you take the car keys away, you're going to make them very miserable because it's cutting off people's independence. So, but that's important. So recognize the possibility that this could be a reversible manifestation of liver disease. It needs to be investigated. And as families and as advocates, we have to advocate for our patients and for their needs and the families' needs.
Thank you. Thank you very much. I appreciate that. What are some of the biggest challenges that we're facing with HE and ACLF in regards to research?
I think Dr. Lai has a lot of thoughts about that, as do I. Unfortunately, research is driven heavily by the investment in pharmaceuticals. So the pharmaceutical industry is heavily driven by investors who need to turn a profit. So research, and this is a frustrating point for me and for Dr. Lai and others, research tends to be focused on those areas where there's an opportunity to make a profit. And this is America, and we're a capitalist system. We understand that. So I really appreciate her comments about how we have to advocate for some areas of significant clinical need that may not be profitable as having therapies for fatty liver disease, and therefore we have to have other sources of funding, particularly from government sources. And Dr. Leib, may you want to comment as well?
Yeah, I mean, there actually are a lot of therapeutics under development for HE right now. None of them other than rifaximin have really come to prime time. I would say that from an ACLF perspective, one of the challenges is that it's a relatively new condition. And when I say new, it really is new in terms of having a name to it. We've always known forever that patients with cirrhosis can have a precipitating event and end up in the hospital with this multi-organ failure. But it's really only been in the last maybe 15 years that ACLF has had a name, and only in the last, even honestly, even as recently as 2015, I would say that when the researchers, I was one of those researchers, were in ACLF, and I would say ACLF, there were other hepatologists who would sort of roll their eyes like, oh, is this even really a condition? So I would say that ACLF didn't really have recognition and acceptance in the hepatology and transplant communities as a defined and distinct condition until very recently. And so if it doesn't even have a condition, we can't even develop target therapeutics. And we're only right now starting to get to the place where drug regulatory organizations, so we need the FDA to acknowledge ACLF as a condition before you can get pharma to devote significant resources to developing therapeutics to it, right? And so this really comes from patients and caregivers. It cannot just come from clinicians. I mean, we have to be involved as well. But the patients need to be out there to tell the FDA, this is a condition, this is real. It's not just decompensated cirrhosis. This is a very distinct condition where all of a sudden my mother, my brother, my family member went from living at home to all of a sudden being in the ICU attached to 15 different tubes and 20 different medications. And so we're just now starting to turn the corner where ACLF is being acknowledged as a distinct separate condition. And being here with GLI, having an entire seminar that is focused in part on ACLF is really a huge step.
Thank you very much. I agree. One of the things that I heard Dr. Manch, I hope I pronounced your name right, mention that HE is completely reversible, or that it is reversible. Is there a time in which you would see that HE remains, there's long-term effects from it? Because for myself personally, as well as several patients that I've worked with in advocacy, they have been told by their physicians to go ahead and have a brain scan to see now while you're diagnosed to see if there's any long-term effects. Is that beneficial at all? Is that even a needed thing to evaluate if there's long-term effects from HE?
Well, there is a possibility that, we say it's potentially reversible or usually reversible. Uh, uh, if a patient remains encephalopathic for long periods of time, it may be less reversible. There may be some. I'm always an advocate for not doing a test unless it results in something you can act on. So
Okay.
I think brain imaging in the initial diagnosis is sometimes helpful. And so if it's available in a CT or an MRI imaging of the brain, I think it's useful for differentiating HE from some other treatable cause, such as, again, these patients fall. They fall at night, they fall in the bathroom, which is the worst part of the house to fall in. And you have to consider that, especially if HE is diagnosed acutely. But in the more severe cases, there are some changes that they can recognize related to the HE, but it also could be predictive of a less reversible or a more permanent state. But that might not necessarily, other than to know about it and to provide the support and the therapy for it, it may not. Once it's less reversible, it's less treatable. I think that the concern about so many of these patients that are chronically encephalopathic is the fact that they're going in and out of the hospital. Every time you walk in the hospital, you're subject to potentially bad outcomes. Something can go wrong. You can get a hospital-acquired infection. You can get an inexperienced staffer or provider. Hospitals are wonderful places. I've spent most of my career in hospitals, but they're also dangerous places and best to be avoided. So, I think the biggest challenge with patients as they get older and sicker with their liver disease is that they have close support from family and other resources available. And we begin to recognize these subtle changes and address them. And if they are due to hepatic encephalopathy, they are very treatable and reversible. Much can be done. There, as Dr. Lai mentioned, there are new therapies. There's other therapies I didn't get into. There's something called sodium benzoate that you can get from a compounding pharmacy that's sometimes helpful. Other things that we do, but we're still kind of dependent on not the greatest therapy. Lactulose is not great and it's been around forever, but it's what we got. And then Xifaxan is terrific, but it's hard for providers to get it to their patients. We have some challenges there.
There
Okay.
are also some small studies that have shown that probiotics may benefit in the management of hepatic encephalopathy. So it is once my patient is on lactulose and rifaximin and still having hepatic encephalopathy episodes, I do really encourage the intake of probiotics. I always prefer natural, and so one of the questions did involve how we support our microbiome through eating, and foods that are fermented are very rich in probiotics. So my favorite is Greek yogurt. And just make sure that there's a range of probiotics or active live cultures on the label, and preferably with less sugar. So plain Greek yogurt would be the optimal choice, sort of a full fat yogurt, because it's got lots of protein in it. And it's got the probiotics as well. So you kind of get, this is the perfect thing to eat as your late evening snack. But other types of fermented foods include sauerkraut. Actually, hard cheeses will count, although those oftentimes are full of a lot of sodium, and they're very highly caloric, but oftentimes with cirrhosis, we care more about just getting protein and calories in rather than worrying about too many calories. And so those are some ideas. And miso is also a fermented soy. So those are just some ideas of fermented foods. But I would definitely lean towards the Greek yogurt, the kefirs.
When you're speaking about diet, is there a particular diet that you view as a good liver healthy diet for us? I know I've heard farm to table or Mediterranean. What do you recommend?
Yeah, absolutely. The Mediterranean style diet is the way to go. I tend not to use the word Mediterranean style diet though, because people just automatically go to like olives and hummus in their head, and they're like, I don't need olives, And so Mediterranean style, it's really just a style of diet. And if you, the keyword to look up with Dr. Google is actually the anti-inflammatory diet. A Mediterranean diet is an anti-inflammatory diet. And the key is just try to get one of those triangles. And it's those triangles where the bottom is full of whole grains, whole foods, legumes, and like as many plants as you want. And then as you get up the triangle, you eat in fewer and fewer proportions. And so dairy goes up. You eat dairy in fewer proportions. You eat meat very rarely. So land meat very rarely, like twice a month. You eat fish maybe once or twice a week. And then at the very top triangle, very rarely is actually super sweet stuff. And it's a strong reduction in ultra processed foods. So it sounds complicated. I think one of the quote unquote easiest way to start shifting your diet is to reduce your reliance on ultra processed foods. Ultra processed foods being things that come in a bag and have more than 5 ingredients typically. Okay. And it's impossible to avoid completely. Most people won't be able to get to 0. But just like you said, farm to table, this idea of you're eating whole, and as much as you can eat whole stuff. And even if you're buying packaged stuff, look at the number of ingredients and try to get the ones with as few ingredients as possible. Things like nuts, for example, will come in a package, but they just have, they're just the nuts with, sometimes a little roasted with oil and some salt. And that's okay. As opposed to the crackers and the cookies with a bunch of ingredients you've never heard of, because those ingredients, those emulsifiers, all of those additives, those are super inflammatory. Your body was not evolutionarily designed to process that. So when your body sees it, it's an automatic trigger for inflammation.
Oh, thank you so much. I really appreciate you both taking the time to speak to myself and other patients out there. I know it's important, and I value your time. Thank you very, very much. I appreciate it, and I hope you have a wonderful day.
Thank you. It's an honor to be here.
Thank you.
You all have a wonderful day. Bye-bye.